Hello, and thank you so much for joining us today for the webinar Augmentations with Allogenic Bone Grafting Materials, the off-the-shelf golden standard. It is a great pleasure to introduce to you Dr. Arne König, who is Professor of Anatomy at the Master School of Dental Technology, Frankfurt, Maine. He has settled as a specialist in oral surgery and implantology in the Surgical and Implantation Center, Darmstadt. He has several publications and lectures at home as well as abroad, and he is president of the Dental Society in Hesse. His aim during this presentation will be to present his own cases, comprising the applications of allogenic bone grafts and the clinical outcomes. We would like to thank Dr. Arne König for being with us today and our sponsor botiss for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. König at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Arne König.
Yeah, good evening. I would like to introduce myself. First, my name is Dr. Arne König. You have heard. After my military career, I've studied dentistry in Frankfurt, and for 12 years I work as an oral surgeon in Darmstadt. Today I want to give you a little glimpse into the experience with human bone material. Since 3 years, we augmentation with materials from human donors. Surely the golden standard is the own autologous bone, but it have some difference. So we give you an experience for the new operation. The insurance consideration is following the tooth loose years ago. Then we have atrophic jawbone, and we gain the vertical bone height. We can see it in X-ray in the later slides. Without augmentation of the sinus floor, we risk biological and technical complications. That what I talk to you is not new. Bone loss is not a current problem. You can see two pictures of anatomical studies of Leonardo da Vinci here and the sinus on the right side. Bone augmentation in medical history, you can see, is not new, 400 years old. In 1668, Johann Merkern covers calvary defects with dog bone, but you can see a little bit later in the 20th century, first bone bank in USA, so a production of freeze-dried bone in USA, and since 1995, application of bone augmentation materials and bioactive substrates for bone formation. You can see it on the next slides. Here you remember the sinus in a very low vertical bone level here on an X-ray in region 2-6, and we have less for 5 or 6 millimeter, and it's too less for implantation without any augmentation. For the anatomical condition, it's important the medial boundary to the nasal cavity and lateral bounded by the bony walls of the cheek and the os zygomaticum. Cranial, you can find it forms the orbital floor, and caudally the sinus floor is situated with the root tips of the maxillary posterior teeth. We have two options for, or different options for bone, different options for bone regeneration. First, the sinus lift in two-stage procedure or one-stage procedure. In the most operations, we made it by two-stage procedure. Sometimes for one osteotomy and lateral augmentation with area crest chips, but it's not a kind for practice, only for a clinical. What kind of materials bone regeneration we have? Autologous bone, that is surely the golden standard, and the combination of autologous bone and bone substitutes materials, and since few years, bone morphogenic proteins. The sinus left is the regions for harvesting autologous bone. It's mostly the tuber maxillae, the linea obliqua, the chin region, but with some risks, and the area crest and tibia plateau. We have used it only for the publication, but area crest and tibia plateau is only, I've said, for the clinical and the maxillary surgeon. After the operations, we have some risks by sinus lifts, mostly the infection, acute sinusitis, perforation to the nasal cavity, perforation to the genuine membrane, loss of the transplant is a risk, and post-operative hematoma and neurological problems. The sinus lift in two-stage procedure. In the left picture, you see the preparation of the lateral window by a diamond drill, and in the right picture on the bottom, you can see the mobilization. Next is the filling of the cavity with cerebone by a botiss and covering with a membrane. Here's an adjacent membrane, also by botiss. Sorry. Here, an X-ray picture by the situation after bilateral sinus lift with cerebone on the left and on the right side in region 1617 and region 2627. Then we left it for 6 months. After the 6 months, the bone substitute material is remodeled into the patient's own bone, the mostly of it. And now we have the possibility to insert an implant. Here 4 implants in the upper jaw and 4 implants in the lower jaw. And we're waiting 3 or 4 months. And following healing is the bone bridges could be inserted. And that's surely the procedure of the most successfully. Yeah, I have risk. I've told you perforation in the membrane of the sinus. Here we have a picture by the operation of there's 2 implants, and with a peri-implantitis, we have cleaned the implants. Then we use, you can hear it, you can see it, the own bone fixed by 2 screws. And then we use the cerebral material fixes by stitches, and that's a picture after 6 months, and you can see it's perfectly healing. Another situation is the loss of the horizontal and vertical bone. Here we use own bone mixed with bone material, also cerebone. The healing time is again 6 months. We use a membrane resorptive, and that's the situation after 6 months. The bone substitutes, it's autogenous, cancerous bone graft and compact bone graft, allogenic or xenogenic by bioos, colors, and so on, alloplastic and genetic. But mostly we use autogenous or allogenic materials. The xenogain has plus osteoconductive and natural bone architecture, and the negative is osteoinductive, the potential allergenic and disease transmission. A few years ago we tried by xenogenic colors. It's osteoconductive, natural bone architecture, allogenic, and it's a wool-like material, and it's a little bit difficult in use. Then come the 90s. We have the Ceresorb, tricalcium phosphate, etc., alloplastic materials. It's maybe osteoconductive, but slowly degradable and filling material. And it feels like a ceramic. Many options, many materials. The assessment criteria for bone substitutes is biocompatibility, bioresorption, simultaneous new bone formation, and the high solubility of the material adapted to the natural bone formation. Of course, radiopacity, no risk of infection, forensic safe use is very important today. Interconnected microporosity, solid structure and easy clinical application. No premature decay, no unwanted activity of macrophages, different forms of granules, and sufficient clinical testing, of course, in the literature. And it's very different and difficult to decide what material I try to use. Here you see an augmentation in front area of the upper jaw. And since 3 years, we use MaxGraft Bone Builder by great loss of bone. The advantage of it is it's prefabricated, it's individual designed for the patient's bone defect after the CT. It's an allogenic bone block and no harvesting and manual adjustment of autologous transplant. There's a low level of pain by the patient and no morbidity and of harvesting side. And you have a shorter operation time and you have only one operation location. How's the technology? It's based on a CT and D4T scan of the bone defect. It's computer-assisted graft design using 3D planning software. And then you get it by the individual bone block test mill of the Cells and Tissue Bank Austria. And then it's ready to use. And the passing is like a piece of puzzle. Here we have the region of 1/6. It's a loss of the teeth. Missing the teeth. For the cut guide, I draw the appropriate line. Here we see the exposed bone. Then first there's a fitting. Here you have the bone builder. And then I prepared the bone builder and equipped with 2 osteosynthesis screws. After all, it was fixed on the upper jaw, and you can see it's a very good passing. And in most cases, the bone builder fits like a piece of puzzle. Here, because of the edges, they are filled with a little material. Here is Max Resorb. And then the situation is covered with a membrane and fixed with stitches. After 1 week, we remove the stitches, and then the healing time is 4 to 6 months. Now I would like to show you operation as a video. In this situation, we have the patient lost the tooth 1-2 to 2-2, completely front anterior. First, we gave a local anesthesia. Then is following the cut. This serve of the 2-1-3 and 2-3, and the cut on the palatinal side. It's a little bit difficult to preparation, because it's very scared. So that is the bone builder you can get it by the tissue bank. Let's see it on the bottom. And on that situation, we have two bone builders. You can use one bone builder for situation 4 to 5 centimeter. It was prepared, and now we fix it by the osteosynthesis screws. The second one. And on the top of it, here you can see the width that I need later for implantation. Or the second one. No, it's not. Flavio Cassani asked for perforation. No, it's no perforation. I know how thick the bone is, and so I know the length of the screws. Few threads of the screw are enough in the bone. Second screw. It's impregnated by the own blood, so I adjust the membrane for covering. And when it's not enough, you can use, of course, the second membrane. And sides I use little little material. Second membrane. The membrane fits snugly. And now the preparation of the mucoperiost. And then we fix it by stitches and close it. Important is that you can move easy to mobilize the mucoperiost flap. That's really important for the healing session. Yeah, you have a risk of recession around remaining teeth. But in the second, if after the implant induration, you can correct it. But not every time. Okay, that was the operation. The real operation time is around about 20 to 25 minutes. That's the first X-ray. You can hear the problem of the tooth. I know we have totally the periodontics here and here, but the patient consisted that we only operate in the front of the upper jaw. Next one, that's the X-ray after the operation. You can see it here, the 4 screws, and that's the bone. And now we are waiting for the healing time and then for implant insertion. Another form of human bone material is the bone ring. It is particularly suitable for loose of a tooth, such as in the anterior region of the upper jaw, here. Same procedure, the cut. this discharge cut here. In the next picture, you can see here the horizontal and vertical bone loss. With a mirror. Now for measure the Japan drill. Then we first the preparation with a diamond drill. Here. Then we use the pilot drill for the lateral implant insertion on the right location. And here you can see the loss that's too thin for only using the implant. Now we use the Japan drill. And then the drill called planator, only for planning. That's the bone ring. Ready for use. Here's the bone ring. First I adjust it. And you can see it's too long. And you can cut it by a cutting disc for the right length. And now that's an insert. And you can insert in high and horizontal and in the vertical. The hole is for an implant, maximum 4 diameters, 3.5 or 4 diameters. Then we go for it like an implant protocol, and then we insert the implant. That's it. And here we had reached the right height. It's better to round off the edges, the completely edges. After all, covered by the membrane, we use JSON membrane. Here it, see it, sortable. I fix it with little nails, 2 little nails. That's a package. You can received little materials by human material, filling, again the mobilization of mucoperiosteal flap, and fixed vestiges. Parallel to the bone, we like to use the own blood for making fibrin. It's for better healing, filling, and that's the fibrin made the membrane, it's a human membrane, by the own blood from the patient. Or we mix it with bone material. So we see the better healing for the bone material in the patient. You can see the great defect by the cyst in the front of the lower jaw. Mixed fibrin with human spongiosa. Is that the case? Diego Navas asked if I can use in the second case bone builder technique. Of course, but it's too small, and so the bone ring has here the advantage. But it's possible, of course. And then covered and fixed by stitches. In that case, the bone builder or that situation in that case would be too small for the bone builder. Because you must fix it by two osteosynthesis screws, and you have no real place to fix it, and you have a too high risk for destroying the root of the side teeth. So the summary and the advantages for the extended defects of the ridge, for the situation required simultaneous horizontal and vertical augmentation in one step. It was a great advantage, individual designed allogenic bone blocks. Very feasible and operator, as well as patient-friendly procedure, less pain, significantly reduced morbidity and risk for patient, because you don't need a second the second surgery location. Blocks are less brittle and based on the cut design can be already adapted to the defect prior to surgery, and no harvesting of autologous bone blocks. That's a really, in my opinion, it's a really great advantages. So I hope I could give you then a little insight of my working with human bones, bone builder, bone rings, and so on. Thank you very much for hearing, and good evening, or have a nice day wherever you are.
We would like to thank our speaker for sharing his knowledge and his expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CE RPCE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care and goodbye.